Good afternoon, everyone. So welcome to this instruction course, or as they call it, the Young Masters course now on Neuroophthalmology. It's nice to be called a young master in one way. And we have this course which is based on the Neuroophthalmology basic examination and investigation. So it's basically a beginner's course, and we have some, it'll be a case-based discussion for a lot of the part. And I am lucky to have with me a very nice panel and, great panel of neuro-ophthalmologists from across the country who will also be the instructors for this course. I am Dr. Digvijay Singh. I am the chief instructor and I'm practicing in Gurgaon, my own practice, and I'm heading the eye department at Narayana Hospital here in Gurgaon. We have with us Professor Rohit Saxena. He is a professor at RP Center, AIIMS, New Delhi, and he's been in neuro-ophthalmology practice for over 2 decades now. I have with me Dr. Rashmin Gandhi. He is director at Center for Sight and again an avid neuro-ophthalmologist in the private sector. We have Dr. Mahesh, who is heading the neuro-ophthalmology at Aravind in south of India. We have with us Dr. Swati Fulgere, who is additional professor at RP Center, AIIMS, New Delhi, again a neuro-ophthalmologist, and Dr. Dipankar Das, who is from Sri Shankara Dev Netralaya from Guwahati, and he's heading the glaucoma and neuro-ophthalmology division there, and he's a consultant. And we have Dr. Ankur Sinha, who is a neuro-ophthalmologist, a glaucoma specialist, a student specialist from Jaipur. He's a senior of mine, a dear friend as well. And we'll be starting this IC with him on talking about the basic neuro-ophthalmology examination, and then we'll move on from one topic to another. And in between, we'll hopefully have a few cases as well, and you guys can feel free to interact. And I hope this IC, at the end of it, makes you confident in looking at a neuro-ophthalmology patient and being able to at least reach a diagnosis and decide the investigation and plan. So, Dr. Ankur, over to you, and thank you everyone for being a part.
Thank you, Dr. Digvijay, and thank you, AIOS, for giving me the opportunity to be here and interact with you. So I'll be talking in brief about basic neuro-ophthalmology examination and how to start neuro-ophthalmology examination. So the clinical evaluation in neuro-ophthalmology starts with a history taking. Then we move on to the ocular examination, which includes visual acuity, confrontation fields, pupil, fundus, systemic examination, and then investigations, typically the ocular and the systemic. So the onset of vision loss is one of the most important hallmark symptoms in neuro-ophthalmology. How it sets on gives us a clue to the diagnosis. So if the onset of vision loss is hyperacute and acute, probably we are having a vascular or traumatic cause. If it is acute and subacute, probably we are dealing with inflammatory or elevated intraocular pressure. If it is subacute and chronic and progressive, probably we are dealing with a space-occupying lesion, chronic or a degenerative disorder of the neuro-ophthalmology. The history taking starts with duration of symptoms, whether they are recent or long-standing. Symptoms, whether they are improving or worsening, associated complaints of headache, vomiting, seizures, systemic history of focal neurological symptoms and comorbid illnesses, family history in terms of hereditary neuropathies, autoimmune conditions, and treatment history, that whatever has been given, and previous investigations, because sometimes drugs can also lead to neuro-ophthalmic disorders. Now, visual acuity is an important baseline parameter. Even if the patient is presented to us after the loss of vision, we can still ask the patient how the vision was at the time of onset of symptoms. Snellen's acuity is good enough for neuro-ophthalmology, but we should give enough time for patient to respond. Check the best corrected visual acuity and with pinhole, and do not forget to check the near visual acuity, as it can be knocked off in certain neuro-ophthalmic disorders. Now, visual fields are very important in a lot of neuro-ophthalmic disorders. They are also a good test to make the patient aware of what he's losing and the potential dangers of neuro-ophthalmic disorders. And we have a full lecture on the visual field, so I'm going to skip that. Pupils, we have to assess the pupillary size, the reaction to light, the near response, dilatation, and testing the afferent pupillary defect. So measurement of pupil can be done with the help of pupillary gauges, which are easily available. We can also use handheld camera or video pupillarimetry. The pupillary size should be assessed in darkness, light, and near, because we want to know what the issue is. The difference between the two pupils of more than 0.4 millimeters is termed as an isochoria. Now, for testing reaction to light, we should have dim surroundings, ask the patient to fixate at a distance. There should not be attempt to close the eyes or look for the near, as people can constrict, and look for the pupillary constriction. speed of constriction and dilatation, pupillary escape, which can be there in optic nerve and retinal disorders where the pupil constricts and dilates again. Consensual light reflex should also be noted. Check for the near response, that is the accommodation, convergence, and the near triad, and check for the pupillary dilatation, which could be a reflex dilatation with a voice or a loud noise or pain. Dilatation lag of more than 15 seconds can point towards Horner syndrome, or it could be normal. And light near dissociation should also be checked, where the reaction to light is almost always knocked off. Now, RAPD can be checked with the help of Marcus gun or the gun phenomenon, where we cover the normal versus abnormal eye, or it can be tested with a swinging flashlight test, where we shine the light in alternate eyes for 3 to 5 seconds and note the reaction of constriction in the light. The neutral density filters can be quantified with, can be helped to quantify the RAPD. And if both eyes are involved, then we can move on to the edge light pupil cycle time, where the small light is shown to the pupillary edge, where it constricts and dilates again because the light is cut off. You count the number of these cycles in 1 minute and then divide it by 60 so that we find out the time required for one cycle, which is, if it is more than 954 milliseconds, that is abnormal. And difference between the two should not be more than 70 milliseconds. Pharmacologic testing can be done with pilocarpine, diluted pilocarpine, cocaine, apaclonidine, hydroxyamphetamine, and phenylephrine, so that we can know whether it is a parasympathetic or a sympathetic blockade, or it is presynaptic or preganglionatic or postganglionic sympathetic defect. Now, this is a case of 12-year-old boy with drooping of eyelids with mild ptosis. We can clearly see there is a right pupil which is smaller than the left pupil, and then he was subjected to MRI because of this. And there was a large paraspinal mass. So this was a case of Horner syndrome, and then patient underwent surgery for benign schwannoma. Another case who presented to us with the difficulty in near vision, we can clearly see that the left pupil is much larger as compared to the right eye. And then the reaction to light, as we see, we shine the light in the right eye, the pupil constricts pretty well. But when we shine the light to the left eye, the eye fails to constrict as good as it was in the right eye. So probably the left eye is abnormal. Then we do the consensual light reflex, where we can again see when the light is shown to the left eye, the right eye constricts well. But again, when the light is shown to the right eye, the left eye doesn't constrict so well. And this is the movement of the pupil. We can see this eye is showing vermiform kind of a pupillary constriction, while the right eye is showing a concentric pupillary constriction. So that clearly we see the left eye is abnormal. And this is at the presentation when we asked to read him for 5 minutes, and then the pupil does constrict. So this was a case of AD's pupil, and then the patient was given asymmetric near-ad with photochromatic glasses. Now, fundus examination is important, should be done after dilatation. Again, we have a full lecture on fundus examination, so I'm going to skip this. Systemic examination must include vitals like BP and pulse, because sometimes you can be dealing with hypertensive retinopathy, CVS, respiratory, abdomen, and CNS, of course, should be done in all these cases. CNS examination should include orientation, gait, attitude, cranial nerve pulses, all from 1 to 12, motor nervous system, at least the power of limbs and DTRs, sensory system, and cerebral system in the form of gait, finger nose test, and dysdiadochokinesia. Now, investigations can be ocular or it can be systemic. The ocular investigation should be color vision, contrast, fields, and electrophysiological investigations. Color vision are important because you can have red-green deficiencies in optic nerve disorders, blue-yellow in macular, and optic neuritis can show up as red desaturation. Formal testing can be done with these Chiaras and other forms of color vision test. Contrast sensitivity is a very sensitive test. It drops before the visual acuity is lost, and it may not recover fully. So it can be done formally with the polydopsin or FACT test. Visual fields, again, they are important, and we will have a full lecture on visual fields. Visual evoked responses will be under electrophysiology. I think we again have a full lecture on electrophysiology. OCT can help us to diagnose as well as prognosticate the cases and follow up the cases. Again, we will have full lecture on OCT. Now, systemic investigations have a lot of blood investigations, include hemogram, ESR, CRP, LFT, RAP, autoimmune profile, including the NMO, MOG, and aquaporin 4 antibodies. CSF examination for oligoclonal bands and IgG antibodies should always be required based upon the case-to-case scenario. Montoux is important because TB can mimic anything in India, so Montoux test is important, which can help us find out. Similarly, we have full lecture on the radiologic investigation, so I would not go into detail. So in the end, I would say a methodological examination and a good workup is a must to arrive at a good diagnosis in neuroophthalmic cases. Thank you for your kind attention.
Thank you, Dr. Ankur. I think that was very nicely summarized. That's pretty much, what the neuro-ophthalmic examination is like. And as beginners, we should try to be as comprehensive as possible in our examination. And, as we learn over time, then we start doing specific individual examinations for, depending on the kind of case that we are seeing. But equally important now with the examination are the supplementary tools. And first we'll talk about is the OCT Neuro-Ophthalmology. And I request Dr. Rashmin Gandhi to take his talk on that.
Thank you. Thank you so much, Digvijay, for inviting me for this course, and it's lovely to be part of it. So OCT has been now gaining some ground in its applications in various disorders of neuro-ophthalmology. So let's see how would you look at it. So if an OCT printout is given to you, from the neuro-ophthalmic perspective, what exactly we are interested in? We are interested in RNFL thickness, and this is how the RNFL thickness average graph looks like. We are interested in peripapillary RNFL thickness graph. The most important is this average thickness, because that's what you will be looking at. In a neuro-ophthalmic disorders, especially in optic nerve disorder, in an acute phase, acute insult, most of the conditions will lead to some or impressive degree of optic nerve edema, which will be reflected in increased thickness on OCT, increased thickness of RNFL on OCT. And if the disease process is unabated or not treated, it leads to RNFL loss, and that will be reflected as average RNFL thinning on OCT. So when this printout is given to you, the green is a normal thickness. Why do we say normal thickness? That means this is the thickness that we expect for that particular age. This is basically compared to age-matched control. But anything which is in yellow or red zone tells you that there is a thinning of RNFL. So this is this particular graph tells you whether there is, here you can see that there is a thinning of RNFL in temporal, superior, and inferior quadrants of the right eye. While the left eye, in this quadrant, you find that it's all green. That means the RNFL thickness is fine, except maybe there is a little increased thickness here. The same would be reflected in the graphs here. You see here, this is the comparison between right eye and left eye, and clearly you can see that the right eye thickness is lower than the left eye. And here you can see the graph of the right eye, which is going down in the left eye and the right eye. You find here that corresponding areas, the graph is going down in the red and the yellow zone, telling you that there is thinning of average RNFL. So that's how you look at it. Now, how do you use this data? There are three main pillars. It can be used to prognosticate what would be the outcome of your intervention. It can be used in progression of the disorders, and we'll look at a case. And rarely it can help. It can be an adjunct to the diagnosis of certain conditions. What about prognosis? Helen Danishmeier and Peter Savino published this paper a decade ago, where they did a preoperative OCT and they looked at average RNFL in patients who are undergoing neurosurgery for parachiasmal tumors. And they concluded that if the average RNFL thickness was thin, those patients had much less chance of improvement of vision or resolution of visual field defect versus somebody who had average RNFL thickness, which was more than 70 micron or so. So what it tells you, if you order OCT in somebody who's undergoing a neurosurgical procedure, and if average RNFL thickness is more than 70, there is a high chance that there will be improvement in his visual acuity and visual fields. The other concept, so that was peripapillary average RNFL. The newer concept, relatively newer thing to look at is GCC, or ganglion cell complex. It comprises of two layers, ganglion cell layer and inner plexiform layer. And this is how the map looks like. Now the newer machines will actually give you these maps together with the average RNFL map. Here, the cooler colors like blue color denotes thinning, while a warmer color like yellow denotes that it's a normal thickness of the GCC. And as you see here, this side, binasal macular side GCC are thin, which gets reflected into bitemporal heminopia. This is the patient with a chiasmal compression. And following surgery, this is around a year later, the visual field has resolved. Of course, there is no change in the GCC thickness. GCC is gaining ground as a much sensitive and an early indicator in a lot of instances. So Chiasmal compression, it shows up. The thinning of GCC shows up even before visual field defect or even before loss of average RNFL. So this is an important use of OCT, both average RNFL and GCC. Use number 2, this is a 28-year-old female with a picture which is suggestive of papilledema. How do we use OCT here? OCT can be used to give you an objective assessment of what is happening to your treatment. So patient comes to you, you do average RNFL, it will be increased because of disc edema. You follow the patient up and you see what's happening. Is there any decrease in average RNFL as patient undergoes a treatment with Diamox or surgical treatment? And it'll give you an objective assessment that yes, the optic disc edema is reducing, getting reflected in reduction of average RNFL. A word of caution, the RNFL can also reduce because the disease process basically is leading to death of the neurons. That will get reflected in GCC. So if you have thinning of average RNFL, but GCC thickness is not affected, you know that your treatment is working. But if GCC also is getting thin in a subsequent OCT, you know that patient is actually losing its neurons. The other important indication or use of OCT is to differentiate between a true disc edema and a pseudo disc edema like drusen. So drusen, the internal contour of the disc will be lumpy, bumpy, while a true disc edema will have a smooth contour, which also will, this is again a reflection of papilledema causing a disruption of RPE and Brooks membrane. Another important use of OCT would be somebody who is coming for a general examination, a general ophthalmic evaluation, and suddenly you find that the optic disc, which looks a little suspicious. Of course, you would rely on the optic nerve function test, but OCT can also help you here. If the same patient has a thinning, then you know that patient had some insult which led to neuronal loss in that eye. There are other uses of OCT like optic neuritis can show increase in average RNFL if patient has papillitis, which will subsequently reduce. In a multiple sclerosis, even in a subclinical or no clinically overt optic neuritis, patient can still have thinning of average RNFL. AIN will have a sectoral thinning and thickening. Other optic neuropathies again will show corresponding average RNFL. Neurodegenerative disorders like Alzheimer's disease and Parkinsonism shows thinning of RNFL, and it can probably in the future be used as a biomarker of these disorders. Word of caution, children, we don't have proper data to use it with confidence. And even in no PLI, you'll have some amount of RNFL thickness up to 30 or 40 because of presence of glial cells. So OCT can be an adjunct in neuroophthalmology. It is still not reached a stage where it can be used as a substitute for a standard protocol. Thank you so much, Vijay.
Thank you, Dr. Gandhi. That was indeed a very important investigation that we now have. I think it's a part and parcel of every neuro-ophthalmologist's tool and something that is very helpful in our practices. I now invite Dr. Mahesh Kumar to speak on visual fields and localizing the lesion. And I think the visual fields are an investigation that have been around for a long time, much before the OCT, and have been used extensively in neuro-ophthalmology. Dr. Mahesh.
Thank you, Dr. Vijay. I'm just opening the presentation. I'm not able to find my presentation. Yes. Sorry for the delay. First of all, I would like to thank Dr. Digvijay and AMOS for having invited me here in this interesting instruction course. So the topic given to me is localizing visual field defects in neuro-ophthalmology. So among all the different visual sensory functions like acuity, color vision, contrast, visual field assumes one of the most important tools in evaluation of a neuro-ophthalmic patient. Among the different neuro-ophthalmic visual field evaluation methods like confrontation, Amsler, kinetic, or static perimetry, one should not underestimate the value of confrontation fields, especially in neuro-ophthalmology, unlike in other branches of ophthalmology. So confrontation fields can be done in 6 areas by simply finger counting upper right and left, middle right and left, and lower right and left. Or we can use a red object in the center and to the right and the left of fixation by using various objects like this, which are commonly found in the outpatient. Or we can simply use a hand comparison to the right and the left of fixation, a gross hand comparison to elicit gross visual field defects. Together with all these methods will pick up more than 75% of the neurological field defects by these alone. So one should not underestimate these methods. So among the other methods of perimetry, automated perimetry has become the gold standard now. And there are certain fundamental differences between the neuro-ophthalmic automated perimetry as well as locomotus automated perimetry. Here we look at the pattern rather than the light sensitivity by looking at the grayscale in neuro-ophthalmic field defects. For example, since the neuro-ophthalmic field defects are absolute field defects and not relative in most instances, we can grossly compare the patterns and which will give us a localizing value. And not only that, we need to keep both the fields side by side, right, or as the patient sees it, right on the right side and left on the left side. And we simultaneously compare both the visual fields, unlike in glaucoma where we may be individually examining the individual field defects. So this will give us a clue, simultaneously examining both the visual fields side by side. And in the localization, we can divide it into pre-chiasmal, chiasmal, or post-chiasmal lesions. Among the pre-chiasmal lesions, these conditions, though not exactly of localizing value, have some characteristic patterns which will help us to detect early signs of visual loss or early instance where we may need to intervene. In addition to other investigations like OCT, which Dr. Ashwin is telling. So in general, there is a generalized enlargement of the blind spot in a papilledema. But as this blind spot enlargement progresses, then we know that our papilledema is not getting controlled and we need to initiate aggressive measures. And also when we are following up a case of post-papilledema, whenever there is a fulminant papilledema like this, as evidenced by all these cotton wool spots indicating there is a lot of ischemia going on, they'll start to begin a generalized constriction of the visual fields. So the moment we see generalized depression of the visual fields, then we know that the axons are losing their life. Axonal death is going on, and we need to intervene before the fundus assumes this pattern of secondary optic atrophy or a post-papillary optic atrophy. So here the visual fields are very important. And in fact, visual field is one of the highly objective methods of following up of patients with papilledema, especially idiopathic intracranial hypertension, where we are treating them medically. Other pre-chiasmal lesions like gliomas, also visual fields have some localizing value where we may need to intervene. In general, gliomas have no vision. There is vision loss and we may not achieve much by operating on the gliomas. But there are certain instances like we follow up the gliomas, and whenever there is a extension to the periphery like this, and whenever there is an extension here, for example, if it grows posteriorly and it touches the chiasm, then we have to remember the chiasmal anatomy where there is an anterior filbrand which contains the infranasal fibers, which will show up in the visual fields as a junctional scotoma or a supratemporal visual field defect in the other side. So the involved side will have total loss of vision, whereas the other side will have early supratemporal field defects, which are called as a junctional scotoma. And at this stage, we know that the tumor is going to catch the other optic nerve or the chiasma fully, and we may need to do some aggressive measures of treatment. Next, in the chiasmal region, pituitary adenomas grow from below. And so these have got some localizing value. So when they press from below, the field defects start typically from supratemporally from above, but maybe not in all instances where we have to factor in the anatomical arrangements like pre-chiasmal and post-chiasmal, but typically it may follow this pattern. And eventually it may become a bitemporal hemianopia or a total vision loss in one side and a temporal hemianopia on the other side. Similarly, in a craniopharyngioma, which presses the chiasm from above, the visual field defects may start from below infratemporally and progresses in the reverse direction. In the post-chiasmal pathway, we have the tract, lateral geniculate body, radiation, and cerebral cortex, and we have simple methods to localize these lesions. So we, in the optic tract, what happens is there is a cross and uncrossed fibers, and majority of the fibers are crossed, 52% versus 48% uncrossed. So in this optic tract, it is just the beginning of the alignment of the corresponding retinal points from both the sides, and so they are not perfectly aligned with each other. And so what we get is an incongruous field defect. So incongruous field defect when they begin to develop. But if this field defect becomes complete, then we cannot say that it is a congruous or incongruous. A complete field defect, homonymous hemianopia, is non-localizing. But if it is an incomplete homonymous hemianopia, and if it is incongruous, then we know it is possibly a optic tract lesion because of the anterior location. And coming little posteriorly, we have the Mayer's loop, which is present in the temporal lobe. PGs can remember like this: it is present below lower part. So the visual field defect will be homonymous superior quadrant anopia like this, or we call it pie in the sky colloquially. Similarly, in the parietal lesions, we have the lesions pressing here. It can either be a tumor or a vascular lesion, and we have other neurological adjunctive signs. We can produce pie in the floor signs. And finally, coming to the occipital lobe, we need to remember the anatomy. There are various locations, and above the calcarine fissure, below the calcarine fissure, and the association areas. And in general, the occipital lobe lesions, they produce a macular sparing homonymous field defect, which is perfectly congruous and complete. Why macular sparing? Because of the dual representation of the posterior cerebral artery and the middle cerebral artery. We have to remember that there is a rare field defect called the temporal crescent. In the anterior part of the occipital cortex, there is a region where it represents the temporal region, temporal field of one eye only, and this will produce a temporal crescent field defect. Thank you very much.
Thank you, Dr. Mahesh. I think that was a comprehensive presentation on all the field effects that happen in neuro-ophthalmology. And the good thing is it's so logically placed, the visual pathway, that if you know your anatomy, you can pretty much localize the lesion once you get a field defect on a visual field. So a quick question here is that how do you choose which field you want to order, or what is the, you know, do you want to do a 24-2, a 30-2, a full field, a kinetic or a static? How do you take that decision?
Yeah, by and large, 24-2 would do for us. But whenever we suspect a junctional field defect or a chiasmal junctional field defect, probably 30-2 would do. If we want to do a quick screening, or where the patient cannot cooperate for a long time, a full threshold 120-point screening test will be good enough for those patients who cannot cooperate for a longer period of times. Supra-threshold test, where the brightness will be adequate, and for those patients who cannot cooperate well. In cases of toxic optic neuropathies, where we suspect central scotomas, we can probably choose a 10-2 visual field defects, which will bring out the finer central scotomas.
Right. I think some of the neuro patients, you know, who are having Parkinson's and all, as you said, the ones who find it difficult to do visual field, the confrontation fields or a kinetic perimetry can kind of help them get through it quickly, which is to give us an idea if there's any absolute defect or not. So thank you for that. We'll now slightly break our pattern. We'll shift to Dr. Rohit Saxena. So this is a little change in schedule because he has to go for another commitment after this. And Professor Rohit Saxena, like I said, has been doing neuro-ophthalmology for a long time at RP Center, AIIMS, New Delhi. And he's seen lots of cases there. And he runs a special neuroradiology conference there. So I thought he's the right person to choose about radio imaging in neuro-ophthalmology. So all yours, sir.
Very much, Digvijay, for the opportunity and for the introduction. And are my slides visible?
Yes.
Okay, thank you. So I'll be talking about imaging in neuro-ophthalmology, and after a particularly beautiful localization by Dr. Mahesh, really, I just would be actually talking about what options we have for imaging and how should we actually approach. So we'll talk about the various investigations available. What do we have? We have a CT scan, we have an MRI, we have advances in now imaging technology from the basic CT and MRI. You have FLAIR, DWI, DTI, a lot of alphabets, which has to make us learn something more rather than just our ABCDs. And then, of course, CT and MR angios and functional MRI. So we'll just go ahead with CT scan first, the most commonly available investigation. And the key reason why we would order a CT scan would be orbital disorders, brain imaging, which would be an immediate urgent intracranial bleed if it's suspected, say, trauma or stroke. And more importantly for our cases, osseous or bony anomalies. The disadvantage is radiation exposure, which has been a lot in discussion during this COVID times. Of course, contrast, because more often than not, you need that. And if you're actually not looking at bone, the bone actually creates a lot of artifacts, which make it difficult for us to appreciate or understand. Of course, it's a very, very quick screening time, very low cost, and can be done where MRI imaging is contraindicated. So a CT would be better than an MRI in conditions you can see where, like in this case, you have a subarachnoid bleed or a calcification within the lesion. So if you're looking for calcification, CT would be your investigation of choice and not an MR, where you may just see a diffuse idea but not be as accurate. So I'll just show you a case of a bony problem. This male patient presented to us with sudden onset loss of vision in the left eye, but he got an injury on the right side. So you can see the subconch hemorrhage here, but the loss of vision was here. Now you need to make sense of this. We thought, is he malingering? So he forgotten which side he got injury to, and you can see the VEPs. The left eye is not showing any imaging, any waveforms, and the right is showing you a very good waveform. So you can do a very good reconstruction of the skull on a CT, and you can see actually the trauma line coming from here on the right side on the forehead, going right up to the canal onto the left side. The right-sided orbital canal is absolutely free from injury. So this can help us to actually trace trauma and where else trauma is there in the eye. A patient of optic atrophy, gradually progressive loss of vision, disc pallor came to us. We thought of compressive optic neuropathy, hereditary toxic, nothing worked. This was the MRI and really was not telling us much, but you could see just one thing gave us a suggestion that the optic nerves are tapering down somewhere. You can see the CT showing us beautifully a compressive optic neuropathy because of osteopetrosis, something that could have been missed if the MRI only was screened and you had not taken into consideration the osseous changes. So CT is important for bony lesions, hemorrhages, an early quick screening space occupying lesion, calcification, and cysticercosis. In this case, we could see a calcified intramuscular cysticercosis in the orbit. Alternatively, the MRI is a choice when you want to look at the brain parenchyma in great depth and try to understand what's happening there. A lot of newer applications have come into the MR, and it's better if you're looking at brainstem, fine lesions like infarcts, small abscesses, tumors, meningeal and dural inflammations, cavernous sinus lesions, and for very small or fine aneurysms. This was a patient who presented with sudden onset unilateral loss of vision. The other eye was normal, left papillitis. Do we image, and for what? Not only are we imaging for space occupying lesions, MRIs now are indicated specifically all patients of optic neuritis, and in which you want to rule out or suspect multiple sclerosis. And also now advances in imaging are telling us that we could suspect NMO-MOG kind of involvement based on the pattern of involvement of the optic nerves and chiasma and of the brain. So it could give us an idea even before serology as to whether we are looking at multiple sclerosis, NMO, or MOG. So essentially, MRI has now become an extremely important investigation of tool. And of course, as per ONTT, it gave us a very good idea about the prognosis of a patient of optic neuritis developing multiple sclerosis in the long term. So one would say do image on all optic neuritis, but essential in recurrent optic neuritis, atypical optic neuritis, which may suggest NMO-MOG. Keen to know about long-term prognosis and acute optic neuritis in children, do a T2 weighted MRI with flare and contrast. Another optic neuropathy, a young male presented with bilateral left eye first, right eye subsequently. You can see the fundus essentially normal, a shade of a minimal pallor on the sides temporally. we are showing a delayed pattern, but a field that is not very, that is equivocal. So would you image? You could say it's a bilateral retrobulbar optic neuritis. You would image because it's atypical, it's bilateral. Already there is disc pallor, and the vision loss was for more than 3 weeks. So atypical image, the patient actually had a pituitary macroadenoma, and that's why imaging becomes important in almost all cases. Another case of progressive loss of vision, basically diagnosed as atrophic papilledema. Do we attempt optic nerve sheath fenestration? You could see there's a lot of fluid, although the optic nerves are also atrophic, so the prognosis was not so good, but there is a good cushion of fluid. So we decided to go ahead with optic nerve sheath fenestration, and you can see the improvement in the fields, and the patient actually recovered to 618. Another case of bilateral disc edema presenting with mild transient obscurations of vision. So basically diagnosed as IIH, but this is a diagnosis of exclusion. You must do MRI to rule out a space occupying lesion. And in cases of IIH, which may present atypically, you may need to go ahead with an MRV to look for venous sinus thrombosis, because that may be an important cause for the raised ICT and may require intervention separate from the IIH. Case of unilateral pale disc edema, possibly NAION. Do you need to image? Really, NAION is a diagnosis they made clinically, but now we have diffusion weighted imaging that may over time be able to help us to differentiate in those borderline cases where we are not clear whether it's an ischemic neuropathy or an atypical optic neuritis like MOG or NMO or MOG that can present in an older population. So till now we used to think older age group, think AION, but now because you have atypical presentations of optic neuritis, maybe in the long term, a diffusion weighted imaging may help. The other conditions where you may require are motility defects. So acute onset third nerve, look for pupillary involvement. You must do an MRA with an MRI. If the pupil is paired, if the ophthalmoplegia is complete, look for vascular causes and follow up. If no improvement, you may require imaging. However, if the presentation is partial, even if the pupil is paired, you need to investigate an image because it could be an evolving aneurysm that needs to be identified early. So an MRI along with an MR angio or a CTO angio would be extremely helpful. And finally, a gaze palsy, a patient with a right-sided gaze palsy, he had a normal CT scan done outside, but clinically looking at gaze palsy, we did an imaging. You can see that this was a lesion, an MRI lesion picked up on the MRI on the paramedian pontine region, missed on the CT because CT cannot image that region well. So post ATD therapy, you can see the patient was improved, and CT may miss these diagnoses. So essentially to say imaging is essential, localize and inform your radiologist what you require to look up. Thank you very much.
Thank you, Rohit sir. I think that's imaging is a very important part of it, and I realized a lot of this as we attended the neuro-radio conferences that you had initiated at AIIMS, and I think they're still probably ongoing, and I'm sure you discuss a lot of these cases there. As ophthalmologists, you know, we should be able to know the basics of looking at a scan, looking at the MRI. A lot of times we realize this, that, you know, what has been reported is different than what you're actually seeing, because, you know, the radiologist is not looking at it from an ophthalmology perspective. So I think that, Professor, you also come across many such cases where you found findings which were not reported other reports. And thank you. I think you have another one to go to as well. So if you can back for some questions at the end, we'll be
sure.
Quite
Thanks, Digvijay.
So one question for you, Dr. Rohit, before you could leave is, yeah. Am I audible or was my audio breaking?
Audio is kind of breaking in the middle, but go ahead.
Oh, okay. Some network issues. So generally, you know, basically in most cases of neuro-ophthalmology, what is your investigation of choice? It is the MR, right? Or do you tend to do the CT?
Absolutely. If it is possible and the patient can afford it, an MRI would be the investigation of choice. But even in an MRI, you must inform the radiologist what and where is the lesion that you are suspecting. It's extremely important because particularly radiologists are not very adept at orbital imaging. So they may miss an orbital apex or an involvement in that region. So it's important to localize the lesion whenever you send for any imaging. Rashmin, any comments there?
Oh, perfect. That's what I would have. Most neurophthalmic issues, you'll have MR. And as you said, you need to inform the radiologist so that he can run the particular sequence. Also, what you're suspecting. So if you say that it could be stroke, he would go ahead and do DWI as you mentioned. I think Digvijay has.
So Digvijay, I think Digvijay is back again. So
yeah, I was just reconnecting on some network issues there. So
sure.
Yeah.
So I think, yeah, as you said, the MRI is important, and to tell the localize, kind of tell the radiologist what you're looking for to get an appropriate report. That's what works. Okay, sir. Thank you. I now invite Dr. Swati to give her talk on electrophysiology in neuro-ophthalmology. Dr. Swati is at RP Center AIMS and looks after the neuro clinic there. All your
Yeah, am I audible now? My slides are visible?
Yes, ma'am.
Okay.
Yes,
Thank you, Digvijay, for including me as part of this IC, and thank you, AIS, for giving this opportunity. So I'll be just talking about electrophysiological use in neuro-ophthalmology. So I would just be taking you all through various cases which we commonly come across our day-to-day practice, and see how we can apply electrophysiology for the diagnosis as well as prognosis of these cases. So electrophysiology, basically, we know that is of three different types that we regularly use: VER, visually evoked response, electroretinogram, and electrooculogram. The main objective of all of three of them is to have an analysis of functional of the neurovisual pathway. Among all three of them, it's the VER which we commonly use as a neuro-ophthalmologist in our day-to-day practice, with some amount of role of ERG. So this is a table which shows how different electrophysiology tests are used and what is their importance in the cases, and what kind of structure they assess. So as I said, VER is the most important investigation that we use in our practice, and more than amplitude, it is the latency that we should be looking for, because it's more specific for neuro-ophthalmological disorders rather than the amplitude, which can be otherwise low in any other ophthalmic situation also. So this was a case one where a 32-year-old female complained of sudden loss of vision in right eye 4 days back. There was pain on ocular movement also. And best corrected visual acuity in right eye was 20/80, while in left eye it was normal. On examination, there was right RAPD, but fundus was absolutely unremarkable. So as we all know, pupil are very, very sensitive test for the diagnosis of optic nerve diseases. So we all know that there's something wrong with the optic nerve, and going ahead with the VER, we found that the latency of the right eye was increased. So this confirms the diagnosis of retrobulbar neuritis. Similarly, there was another case where a 31-year-old male complained with sudden diminution of vision in the right eye for 15 days with mild ocular pain on eye movements, with mild headache on and off. The right eye vision was 1/60 with absolutely normal PR. The left eye vision was otherwise normal with except one line loss. The pupillary reaction, again right RAPD was present, and again anterior and posterior segment remarkable. So as we all can understand with the clinical picture that this is probably a case of optic nerve disorder, and considering the age and other clinical features, probably a case of again a retrobulbar neuritis. However, sometimes we may have the one eye presenting as retrobulbar neuritis, the other eye may also show some kind of increased latency on VER, which is suggestive of subclinical involvement of that eye. Patient was treated with IV dexamethasone for 3 days as a common practice in this institute. And we found that his VER improved gradually in both the eyes, but there is a possibility that VER improvement, as shown in AONTT trial, takes some time. So even after the recovery of vision, color vision, visual fields, the VER latency may remain abnormal in these patients for a long time. So there was a study from this center where we have found that the VR latency not only is decreased in the involved eye, which is the optic nerve eye, but also in the cases of multiple sclerosis where the optic neuritis was not present. So it may be a sign of some subclinical involvement or demyelination going in visual pathway in cases of multiple sclerosis who do not present with frank optic neuritis. So that's a subtle sign of demyelination in these cases. So next case was a 30-year-old female who had progressive loss of vision. She had very poor vision in both eyes with both pupil reaction not at all reacting to light, and fundus was suggestive of atrophic papillary edema. She was eventually diagnosed as a case of IH. Now we don't know whether we should go ahead and do an optic nerve sheath fenestration in such cases, or we should give patient a prognosis of a very bad prognosis regarding the visual improvement. So VR in these cases may sometimes help because if there is some kind of waveform pattern on the flash VR. So if you have a very poor visual acuity, doing a flash VR is a better choice than doing a pattern VR, because the pattern VR may show extinguished response in some cases, while the flash VR may show some response, some kind of waveform in these cases. So if you have some kind of waveform present there, we may go ahead and do an ONSF. That's what we did in these cases. And we found that the visual acuity improved, not very remarkably, but up to 4/60 with a severely constricted visual field. And there was improvement in VER waveform as well. Now, there is another case of a 24-year-old male patient who was receiving ATT for past 3 months and had a visual acuity of 612 with both eye pupils not showing any abnormality. So we suspected that this probably is a case of ethambutol toxicity, went ahead and did VER, and we found that the VER was more severely affected than the vision, and the latency was quite significantly increased. So it just helps, not only helps in diagnosis or confirming the diagnosis of ethambutol toxicity. The study from this center has shown that around 14% of the patients may show some kind of loss of amplitude and increase in latency if they are on ATT for more than 3 months. So 14% of patients may show subclinical toxicity due to ethambutol in cases of ATT. Recently, another study has been published from this center where around 40% of patients show more than 2 standard deviation of increase in latency, suggestive again of subclinical ethambutol toxicity. So even if the vision is good, even if the color vision is not affected, visual fields are normal, VR is one of the way to diagnose a subclinical toxicity in these patients, and these patients need regular follow-up, more frequent follow-ups to monitor for the development of the clinical toxicity in these cases. Sometimes it is complementary to OCT as well to diagnose the subclinical toxicity. Now, this was a case 5, which who was a 1-year-old child who had the history of development delay, and the mother wanted to know the prognosis. So the mother asked whether my child would see or not. In such cases, if we have flat VR, we may tell mother that the child may not be able to see. So it's one of the way to assess the visual potential in children who are non-cooperative. So it also helps in assessment of visual potential in opaque media. Then in non-organic visual loss, the VER may help in detecting some kind of functional visual loss. This was another case which we frequently see in our day-to-day practice, where a patient presented with poor vision, and on examination there was just a disc pallor that was present. So VER was not so helpful. We went and did ERG, and we found that his photopic ERGs, which is because of cone photoreceptors, was absolutely extinguished as compared to the scotopic ERG, which had a good waveform suggesting of the cone rod dystrophy. So in these cases where the full field ERG is not good enough, one may go ahead and do multifocal ERG. To conclude, the electrophysiology helps in diagnosis of the cases, also in diagnosing subclinical cases, differentiate retinal pathologies from optic nerve pathologies, also to differentiate organic from non-organic cause, and to determine the visual potential in certain patients. Thank you.
Hello, Sadhu. Thank you. Am I audible? I'm just logging from a different internet connection.
Yes, sir, you are audible.
Yeah. I think some issues there on my end. So yeah, thank you. I think for the talk, I lost in the last 30 seconds or so that was missed out. But I think it was, so electrophysiology is again one of those very important tools which, one needs to have as on our armamentarium as neuro-ophthalmologists. Probably equally important to us or more important to us than even the retina specialists, I think, to give us a good idea of what we're dealing with. And so I think, in your kind of day-to-day practice, how many times have you found that, clinically everything looks to be fine? And how often do you look at that as a follow-up for your patients?
Sorry, Digvijay, we lost you for some time.
Oops. Am I audible again?
Yes, you are.
Yeah. I said, are there cases where electrophysiology alone has helped you out in, helping establish a diagnosis where you were, having some confusion?
As a standalone measure, maybe they may not, unless it's, you want to diagnose subclinical toxicities in cases who are receiving ATTs or any other kind of toxicity. And mainly in cases where you have normal visual fundus, especially cases like rod cone dystrophies, other macular degenerations, where you are not able to make a clinical diagnosis, these tests definitely help. Otherwise, they help they are kind of supplementary to your clinical examination, where they confirm your clinical diagnosis.
Right. So I think that's great. Dr. Dipankar, could you take your presentation? I'm just trying to figure out some internet issues here. If you could, if Dr. Dipankar, you could present on vision loss in normal fundus in the meanwhile, while I just set up things on a different internet connection here. So over to you, Dr. Dipankar.
Yeah, thank you. Are my slides visible?
Yes.
Hello. Yeah. So, good afternoon, everybody. And at the outset, I'd like to thank Dr. Digvijay for giving me this opportunity to present in this instruction course. Also, I am thankful to AIOS for this topic, which is very interesting to see the vision loss with normal fundus. I do not have any financial or commercial interest in any of this material discussed in this presentation. This is purely an academic one. Now we see the mind and eye connection, the poor vision normal fundus. What are the causes? The mind should know before the eye sees. So now we should always see this dictum when you hear hoof beats, what you expect, horse or zebra. Horse is for common diseases and zebra would have been a rare disease. Now, what are the common things that we see? For example, with normal eye movement in children, there may be refractive error or amblyopia that can give rise to a low vision with normal fundus. As Swati mentioned, non-organic visual loss such as malignancy sometimes can pose problem. And one very important thing is delayed visual maturation, where vision improved to normal by 6 months, where the child can present in this situation. Early retinal dystrophies such as cone dystrophy or Stargardt's can present in this scenario, and cortical visual impairment sometimes can present like this. And in adult, as some of my previous speaker has shown, retrovalvular neuritis with pulse imaging and other visual field changes, nutritional amblyopia, and the paraneoplastic disease, either associated retinopathy or melanoma associated retinopathy, can pose low vision with normal fundus. In children with abnormal eye movement, a different scenario where leber congenital amaurosis can present. You have a clinical sign, for example, eye poking, then rotatory eye movement, etc. Nystagmus. Then achromatopsia can pose this problem. Extreme decisive congenital stationary blindness sometimes can pose this. So to go about investigating these cases, let us take a case scenario. A 28-year-old lady with a sudden loss of vision in the right eye. Now she had a ocular movement while she has an eye pain in the right eye, and there was when eliciting the ocular movement, there was pain mostly in the retrovalvular area, the boring pain she felt about. Vision was 624 and 18 in the right eye. Left eye was normal. There was relative afferent pupillary defect, and impairment of visual color vision was seen in the right eye by ECR and FM100 test. There was diminished contrast sensitivity, as Dr. Saxena has shown in his slide by Spelly-Robson chart, was seen in our institution. Visual field defect was centrocecal, as shown in the figure here. Now, obviously, our diagnosis, we want to rule out retrovalvular neuritis, and MRI was given, as Rohit showed in his wonderful pictures of MRI. Here, multiple hyperintense lesion, periventricular lesion was seen, along with thickening of the optic nerve. So this is a case of a retrovalvular neuritis. And you see, in our undergraduate classes, it was told, the dictum was told that in retrovalvular neuritis, the patient does not see anything, doctor does not see anything. So this is a wonderful examination. And in VAP, as Swati showed, there was a minimal amplitude changes, but there's prolonged latency. Now, important thing is that the pattern VAP can be useful to show the delayed response. There is also some center in abroad, they have a multifocal VAP also in a new armamentarium of electrophysiological test. Now, OCT, if you see, it is, and this was in the follow-up of the case, and so that red zone, what Dr. Rashmin showed, was not entitled, but you can see the yellow zone touching the black one. So here, important thing, as Dr. Rashmin has mentioned, that retinal nerve fiber analysis along with GCL IPL change, which is more sensitive. Okay, an important thing for retrovalvular neuritis is more for a myelin oligodendrocyte like made MOG optic neuropathy. Sometimes there may be, you need to investigate more in atypical optic neuropathy, okay, with all these collagen and other diseases. Neurologists sometimes do a CSF analysis for this oligoconal band, and apart from it, as Dr. Rashmin has shown, that there may be other, and Dr. Saxena has shown the aquaporin for a NMO spectrum disease sometimes can be helpful. But here is one important point. If you're suspecting a Leber's hereditary optic neuropathy, it is usually young male, maternally related male, bilateral, and vision recovery is very less comparative to optic neuritis, where genetic counseling and other testing are helpful. So few tips about the OCT is that the retinal nerve fiber layer thinning in ethambutol or linezolid like antibiotic toxic optic neuropathy OCT can helpful in early toxicity and quantify the loss of retinal nerve fiber. In Leber's congenital amaurosis or early onset retinal dystrophy, retinal thinning can be seen. Fundus albipanctus, and particularly for Okuchi's disease, which is a congenital stationary blindness, but accumulation of rhodopsin in the rod outer segment can be an important finding. And in achromatopsia, the ISOS junction, and outer nuclear layer, as well as flattened foveal counter can be an important tip. The second case, already some of the instructor has shown that in what happened in TB cases with Ethambutol. This is a 33-year-old man with pulmonary TB, was on ATT for 2 months. The INH rifampicin, pyrazinamide, and Ethambutol was given. Now, the person developed dimness of vision by 5 weeks after starting of ATT. Vision was 6, 12, and 18, almost symmetrical in both the eye. And you see there's a normal fundus and the low vision. Now, the color vision defect was seen along with 100U test. The important thing, what Dr. Saxena has mentioned in the first presentation, that for toxic neuropathy is usually blue-yellow to start with, but for optic neuritis, it is usually red-green or mixed pattern, because in blue-yellow, because the drug affects the foveal part first. And this patient in multifocal ERG has reduced response in the mass response in the right eye, and left eye there's a basic trace defect was noted. So in clinical part for toxic amblyopia, proper history is very, very important. Systemic medication, substance abuse, alcohol and smoking can add the problem. Associated metabolic disease such as kidney disease can accelerate the problem of toxic optic neuropathy. Familial history of hereditary optic neuropathy is very, very important, because they can sum up the condition very fast, and history of headache and vertigo is important. What usually we miss in the investigation for toxic neuropathy is the blood culture for the toxin and urine analysis for specific toxin, heavy metal screening. And if you see bilateral involvement, it is better to see the serum vitamin B12 and folic acid. Now, case 3 is very, very interesting. 62-year-old lady, visual loss in right eye 6, 12, and 12, left eye 6, 9. So bilateral dimness of vision, but very peculiar problem she complained was episode of darkness and feeling of strands in the visual field, which lasts for minutes to hours. There was a defective visual color vision. Fundus was within normal limit. Okay, but there was a history of endometrial carcinoma 11 years back. 3 years back, she has done a PET CT, whole body, where abdominal PET CT showed para-aortic node 3 months, but recent PET scan was normal. Now you see there is a negative waveform in ERG where there's a prolonged latency, but few changes were in the amplitude. MI was normal. Here you see the OCT. Here the OCT showed sensorineural detachment, but very carefully you observe the RP layer. There's undulation of the RP, which can tell you that there may be an antibody or a metastatic like lesion can happen, like a carcinoma-associated retinopathy, where the autoimmune mechanism can happen that does not may present as a metastasis as such, but antibody reaction can happen there. So few tips for CAR is that a visual symptom may precede the signs of systemic malignancy by 3 to 12 months or so, no gender predilection, seen mainly in the elderly, decreased visual acuity, color vision defect, paracentral scotoma in the visual field, impaired dark adaptation, complete workout for the metastasis, very, very important. Here is the important tool, what Swati showed an electrophysiological presentation. Here, ERG may have a high, maybe advantageous role more than OCT in detecting the early changes, and circulating antibodies such as enolase and recombinant can be important finding. Now, some additional important tests for this, fundus autofluorescence, the neuroophthalmologists do not do, but the retinal specialists do this test often. In some cases of X-linked congenital stationary night blindness, typically demonstrate decreased background autofluorescence, which is consistent with the dysfunctional retinal cycle. I have seen some of the paper in the advanced center where microperimetry is used to detect the what you call multiple sclerosis, the retinal mapping, particularly in the macula, is very, very but most of the centers in India do not have microperimetry to add in the diagnosis of neuroophthalmology. For LCA and early onset retinal dystrophy, genetic and molecular testing, I've already said, is very, very important. So the take-home message is basic investigations are very, very important. As Professor Saxena told in his presentation, the role of color vision, visual field, newer generation of OCT, such as HROCT, multifocal ERG, aid in various diagnoses of reduced vision and normal fundus. Investigation should be case-based or tailor-based. Thank you for patient hearing.
Thank you, Dr. Dipankar. I think that is an excellent presentation and good cases to share. You know, one of the types of situations that we often come across where there is a vision loss and a normal fundus are sometimes malingerers as well. You know, where the vision loss is what they present with, but actually it's not really a true vision loss. And that's again something where you can use clinical examination and tools like electrophysiology in order to help you rule out, you know, whether they're having some kind of a malingering or some kind of a hysterical vision loss or not.
Yeah, and that's what you do in functional vision loss or malingering. You can do a simple VAP. VAP is it's almost it's very normal comparative to the functional loss. Apart from this, the clinical tests, all these tests, the mirror test, etc., can be done in the clinics to elicit malingering.
Right. Thank you. So I will now move on to the the last talk of the session. And this is again going to be a lot of cases along with it. On pale and swollen discs, so how to approach them, how to, what to look for. We've already discussed what if the fundus is completely normal, then what is it that you can look for? And this is a situation where there have got a disc which is either pale or swollen, and pretty much this kind of covers whatever changes you'll find in the optic nerve. So the history has already been covered well by Dr. Ankur in the initial examination portion. So you just need to know history of diminution of vision. Since when is it? Was it sudden, gradual? And this is just very basic points, whether it was transient or permanent. Are there any associated factors along with that? Is there any double vision that the patient is having? Any kind of a headache? Any kind of a... So essentially, the idea here is I'm just giving few pointers. This is not a comprehensive history list that you have to take, but this is what you want to look for predominantly if you find a pale disc or a swollen disc that the person has. So similarly, focal neurological deficits, so ocular movement changes, so all this becomes important. On the examination, all this is already being covered very well in the beginning. So you look at the ocular movements, look for ptosis, look at the pupils, look at the, the fundus. Obviously, we're looking at a disc edema and or a pale disc. So based on that, there'll be different etiologies that can come across. You need to do a color vision and a contrast, very important tools for the neuro-ophthalmologist. A confrontation visual fields already emphasized by Dr. Mahesh. So all this should be done by you. Now, if you see a pale disc, there could be two reasons for it. Either it could be a pale disc with very distinct margins, a good looking optic nerve cup is there, vessels are well defined. This is known as a primary optic atrophy, right? And this happens when there are primary diseases, etiologies of the optic nerve. Then you could have a pale disc like the one on the right of the screen, where the margins are blurred, kind of dirty looking, sometimes grayish, the cup is obscured, the vessels may be looking abnormal. This is a secondary optic atrophy, and this happens when the disc an optic atrophy sets in after disc edema. In terms of the edematous discs, you could either have mildly blurred margins with hyperemia, as is seen in papillitis in the first image, or you could have a segmental kind of a pallor or a segmental kind of a disc edema, as in the second image, which is generally what we see in ischemic neuropathies, or you could have a disc which is very much edematous all throughout, it's diffuse edema, as is seen in the third picture. This is what we often see in papilledema. So again, in edema, try to compartmentalize which one of these is it closest to. Now, what are the investigations? All these have already been covered. So you want to look at the visual fields that are important, particularly for constriction of the field, if there's any ortitudinal defects, hemianopias, central scotomas, any kind of a blind spot enlargement. So this will be seen in the disc edemas. In optic neuritis, you'll see central scotomas. Ischemic neuropathies will come across ortitudinal field defects. We'll come to some of those in the cases. Then the OCT for looking for the actual peripapillary area, as has been well defined. Then the electrophysiology is important. We want to look at the P100 latency and the amplitude, and neuroimaging, which is the CT and the MRI. So all this has already been covered. Pale discs or swollen discs could be one of these many etiologies, right? From hereditary all the way to inflammatory, paraneoplastic. So there is a huge number of etiologies, but the basic presentation is similar. Either it's going as a pale disc or an edematous disc. Let's look at a few cases. So in the first case, we've got a young male patient who's presenting with a vision loss in the left eye, which is a no PLI, and the right eye is having a normal vision after a road traffic accident. So here we are seeing what it looks like a primary optic atrophy, right? And this is something we can see in a traumatic optic atrophy. traumatic neuropathy. And we do an imaging here. At the CT, you can see that there is a fracture at the optic canal area. There is a medial orbital wall fracture as well. So a primary optic atrophy is going to be seen in traumatic optic neuropathies where there is some kind of either a direct damage or an indirect damage to the optic nerve. So again, identify that it was a primary optic atrophy and you can have your differentials. Another case here, and a lot of these are classic cases, of course, it takes a little bit more thinking to sometimes come up with differentials, and we'll see those cases as we go along. So here you've got a 30-year-old female who's presenting with gradual vision loss in both the eyes. Vision is about 6/12 in one eye and 6/18 in the other eye. And you can see here that there is a disc pallor again in both the discs. Margins are well defined. You can see that it's almost a symmetrical bilateral kind of a disc pallor. And something like this, when both the nerves are affected, then you need to start thinking where could be the common origin. And the common origin very often would either be seen in toxic neuropathies or nutritional deficiency, which is affecting both the nerves, or something like a compression at the back, like a pituitary adenoma, typical age group, progressive, gradual decrease in vision. You must do a visual fields, and that itself gives you the answer. You can see a bitemporal hemianopia right here. And if you do an imaging, a large pituitary macroadenoma sitting there. So again, primary optic atrophy, you're looking at a compressive etiology. This is a young male patient who's presenting again with some gradual decrease of vision in both the eyes. The fundus is showing again a primary optic atrophy. There is a disc pallor more in the temporal than the nasal. When you look at the visual fields, you can see a generalized depression, but on a pattern standard field, you can see on the pattern deviation that there is a specific central depression in both the eyes. So this is something that we could possibly see in different etiologies. One among others is toxic optic neuropathy. The other could be Leber's hereditary optic neuropathy in a young male. Then you could be looking at nutritional deficiency optic neuropathy. It could also be bilateral retrobulbar neuritis, but the more frequent ones are the ones I've mentioned before. And again, based on that treatment, based on that, your investigations would go on whether you want to do an imaging next, which is something that you must do whenever both the nerves are involved, or a genetic testing if you're suspecting Leber's, or you must, based on the history, you can tell whether it is possibly a toxic optic neuropathy or not. But again, the visual fields and the fundus picture gives us a direction, which direction to go at. Now let's look at another case. Here you're seeing there is a young patient, a middle-aged patient about 50 years old, who's having a loss of vision in the left eye over some time. There is occasional headaches. Right eye looks completely normal. The left eye disc, you can see, is slightly dirty looking. Not completely edematous though, but it is grayish looking. Margins are slightly blurred here. And you can see that this is going into what is an atrophy kind of a picture. It's a whitish disc, no longer pink. And in the right eye visual fields were normal. The left eye vision was too poor to do a visual field there. And there was a mild proptosis. So how do we approach this? So now we're looking at something which is causing possibly a disc edema in one of the discs, or a mild disc edema at best, and that is going into a secondary optic atrophy. So whenever that's a situation, in the kind of scenario that we are seeing now, you have to think of imaging. So disc edemas, you must image. You could have other causes such as ischemic neuropathies as well, but predominantly you must start thinking of image. There's a mild proptosis, so that again is a sign towards that direction. And here we can see there is a space occupying lesion right at the orbit. There is a meningioma extending there, and that is what has compressed this nerve, caused some edema and a secondary optic atrophy. The next case here is a 32-year-old female patient who is presenting with a vision loss, sudden vision loss in one of the eyes. You can see here that there is a disc, which is a hyperemic looking disc. Margins are slightly blurred. In that case, the vascular architecture is good. So this is possibly a case of papillitis. So again, a hyperemic disc edema, I'm thinking of papillitis in a young female patient in her 30s. And you want to do investigations further. You just to look at an MRI because you want to do multiple sclerosis. You want to do a full neurological examination. And to confirm your diagnosis in the vision, you can do an electrophysiology, a visual fields, an OCT. So these are the tests, investigations that you could take on. Again, put it into the bucket of papillitis. The next case here is again a young female who's obese, who's overweight, who's presented with bilateral discs which are very swollen. An MRI has been done based on papilledema, and that's the first thing that you must do whenever you see a papilledema. It was within normal limits, and on basis of certain investigations, it was diagnosed to be a case of idiopathic intracranial hypertension. And that, again, so the first investigation here, most important, you don't need to sit into a field first, you don't need to do any electrophysiology. You look at this picture, go for an imaging. Because if there is an ICSOL in the brain, then you need to get that operated soon. It is a life-threatening situation. Here, after that, you can do specific investigations such as look for, you can do a venogram, a dural sinus venogram in the brain to look if you're finding any venous sinus thrombosis. But more importantly, the imaging is the first step that you must take up. The next case is a case of a elderly woman who's having hypertension, who's had a vision loss on waking up in the morning one day. As you can see, the vision in the right eye is less, the left eye looks normal. If you look at the disc in the right eye, you can see that there is a slight edema, there is a sense of pallor in the disc. You can see here on the OCT that the disc is edematous here, and on the visual fields, there is a depression with a kind of a more in the orthogonal area, not a classic orthogonal defect, but this is a case where you've got a segmental edema, segmental pallor. You need to start thinking of ischemic optic neuropathy. That's what was diagnosed in this particular patient. The blood pressure was controlled. She was put on certain sense of oral steroids, did show some improvement, but it did lead to what is a secondary optic atrophy, as you can see in the picture here. There's a pale disc with a dirty, with an unclear margin. So the take-home messages from these cases is, of course, you must approach to each case in a systematic manner. And when you do that, then you are in a position to put each of these cases into whether it is a typical case or an atypical case of something, and put each disc edema or disc pallor into certain buckets. Is it a primary optic atrophy? Is it a secondary optic atrophy? Could it be papillitis, an ischemic neuropathy, disc edema, papilledema? So once you're able to put your particular patient in one bucket, that's when you can start investigating further to reach a diagnosis. So it's very important to, in the beginning, at least have in your mind possible way of how you would approach each case. And yes, there are a lot of atypicalities. These are some classic situations. So there are a lot of confusion sometimes. And that's where, an expert neuro-ophthalmologist can help you out. But at least you would have already had a set of differential diagnoses with you before we get on to that. So we have a little bit of time now. We can do a short panel discussion. And to do that, I think I would start with Dr. Rashmin Gandhi, and if there are any audience questions, you can please put your questions up in the Q&A section below. As of now, so Dr. Rashmin, sir,
Dr. Rashmin, I think has left.
Oh, I think he had to go for another thing. Is it okay? And Dr. Ankur, you've also spoken on OCT, in the past. I know in one of the previous lectures that we had earlier on. How often do you look at doing a ganglion cell layer thickness versus an RNFL alone? Or do you think RNFL can pretty much give us a good idea? One doesn't really have to have the GCC module in day-to-day practice.
Only OCT is not the thing we are banking upon. We have to look at the whole picture, kind of as a profile of the patient. So if you're thinking in terms of toxic optic neuropathies, where both the things would help, the GCC as well as the nerve fiber layer thickness. But if you're thinking in terms of disc edema, then probably we're looking at the nerve fiber layer in the initial go, so that we know how much thickening it has come. And then based upon the increased thickening and maybe the Cooper-Smith angle, we can help us to differentiate whether the disc edema is because of papilledema or ischemic optic neuropathy. So that way we have to find out what we are looking at. If you're looking at neurodegenerative disorders, yes, the macular scan and the nerve fiber layer, both of them are important.
Right. So I think that's what, if catching something early, the GCC can help you in particular kind of disorders. But most of the times, I think by the time the patient would present you, RNFL would show some changes or the other.
Yeah, it's more like degenerative disorders if you're looking at. We talk about then the GCC is going to help you. Otherwise, maybe in the pituitary adenomas also it can show you something, but then not in the disc edemas which you are looking at.
And the next question is, I think, to Dr. Swati. Ma'am, we often do VER goggles for the very young children because we can't do VER flash or VER pattern. And the values, sometimes, you are still seeing some kind of a pallor, but the values often come normal. So how reliable are the electrophysiology? How much should we rely on them is the first question. And second, how do you choose whether you want to go for a flash or a pattern in slightly older children or adults?
Right. So I would like to answer your second question first, that if you have kind of, some good vision, say around good vision where your patient can fixate, you may choose to do a pattern VER. But if there is no fixation at all, especially in child, especially with cortical visual impairment, children who have that, they may not fix at all, and they may not be very cooperative also to look at a pattern. Doing a flash VER may be a better idea in them. Same is true for adults who have very, very poor vision and cannot fix. Maybe doing a flash VER is a better idea in these cases. So I'm sorry, what was your first question, Digvijay?
About VER goggles.
Yeah, so
VER goggles is the first question.
Yeah, VER goggles. I think
VER goggles.
Yeah. So As you said, if the discs are pale and the VR goggle is still showing some response. So I think we just recently concluded a study on patients of CVI, where we found that even though there is some kind of dyspallor because of the insult, ischemic insult that happens in perinatal period, these patients do show some response on VER. And on follow-up, we found that even if they don't develop the normal vision, they develop some kind of visual acuity, some kind of visual potential is there. So in these cases, VR definitely gives us an idea that this patient will have some kind of vision, maybe later on, if not now, because it is seen that after some point of time, say around 6 months, 8 months, or a year or so, they do develop some visual acuity. So that way, yes, it gives you a kind of indication.
Right. Dr. Dipankar, so you're wanting to add something?
Yeah, this is an important thing because how you diagnose, as what it told, is the right perspective way to do the test. I have nothing more to add.
Okay. Dr. Mahesh, you've spoken on the visual fields. Now, in neuro-ophthalmology cases, many a times the vision may be poor. There could be central scotomas, and the fields are not necessarily in the most reliable, situation. So, how do you interpret fields which are somewhat reliable? What is it that how do you differentiate that from probably a badly done field?
As you said, in many instances, it's really difficult to interpret the neurological field effects, especially in patients who are neurologically compromised and other similar instances. So in those circumstances, it's really difficult to interpret them exactly as per the localizations. So we need to correlate it with our clinical findings, the fundus photos and the fundus examination and other things. By and large, we look at the basic reliability indices, and mostly we have to correlate it with the clinical findings and clinical examination. That's what I would do.
Right. I mean, that's always kind of been a challenge. I've seen that.
Can I add something here?
The field, yes.
Like most of us in the private practice in the institutions, we have Humphrey visual fields, and in neuro-ophthalmology patients, it is advisable to have Goldman fields because the perimetrist can monitor how the response is. So even in the Humphreys, you can slow down the responses. There is an option of slowing down the visual field even when the test is in the progress, because at times the neurological patients are not able to respond in time. So the perimetrist has to be taught that, this patient is going to be slow, so you can slow down the test speed. So that way, maybe we can bring out better of the fields as compared to the just running through the normal visual field we get through.
That's a good point.
I think that's an interesting tip. It's there in all the Humphrey perimeter.
Yes. Even when the test is in progress, you can slow down the speed. You can just change the test speed when the test is in progress itself.
Right. And Dr. Ambu, you spoke about the examination. So in terms of confrontation visual fields, is that something that you feel every ophthalmologist should be in a position to do quite well?
Yes. Confrontation visual field is very handy in the OPD, and it helps you pick up a lot of gross things immediately. So neuro-ophthalmology is about suspecting something and then trying to figure out what particular investigations you want. In isolation, we just can't talk about, imaging or electrophysiology or fields or, pupillary examinations. We just suspect something and then build the investigations around that. So confrontation is one thing. I think Dr. Mahesh also stressed that we should be doing it in the 6 quadrants. If not 6, at least 4 quadrants should be done, because we think about a quadrant, 1 quadrant at least in the neuro-ophthalmology rather than the hemi field.
Yeah, that's very important for those intracranial space occupation. You can pick up those very grossly. You can pick up immediately. You can diagnose that this is may have this problem and confirm with your field test.
Yes, and it is also important when you don't have, patient has good vision enough to do Humphrey fields or Goldman fields. So a confrontation perimetry may sometimes help in those cases if the vision is poor.
No, it may help even in the private practice. You're ordering somebody who's paying you $2,000 for a visual field, and you tell the patient, look, I am suspecting there is some problem in the visual field in this particular area. So I would like it to be printed and show you in black and white. So that way the patient can actually, get more feeling that yes, he's losing something and he can get the visual field done.
Right. So I think it's been a wonderful session. Thank you everyone for your time and participation. And I hope this session has, helped instigate among some of the, the newer members in the members in ophthalmology who are getting new into neuro-ophthalmology to take it up, to, look at such cases. And, it's something that is, if you do it logically, systematically, I think anybody can at least make a basic diagnosis of neuro-ophthalmology and look at a patient. So I thank all my co-instructors for this session. I think it's been a wonderful session and we've had a good discussion as well. And we have another session now in Neuro-Ophthalmology by Dr. Swati, starting shortly after this. And we hope to see you all tuned there. Thank you. Thank you, Dr.
Thank you, Dr. Digvijay.
Thank you, Digvijay.
Yeah, thank you.
Thank you, Dr. Mahesh, Dr. Deepankar, Dr. Swati, and Digvijay.
Thank you so much.
Yeah, thank you. Thank you.
Thank you so much. I thank everybody for this wonderful session. Thank you so much. And also I thank Digvijay Singh, sir, for leading this session. Thank you, sir.
Thank you.